Welcome to today's webinar. Thank you for joining us. My name is Sarah Muller-Robbins, and I am the Director of Education for the Partnership for Maternal and Child Health of Northern New Jersey, which is providing today's program. Our webinar today is titled Cannabis Use with New Parents and Breastfeeding. I would like to review some information before we get started. You will receive a link to post-program evaluation immediately after the webinar ends, as well as via email. Please complete the survey to provide us with feedback on the program. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation survey. Please indicate on your survey if you need CADC or nursing credits. Certificates of completion will be sent via email within 1 week of the webinar broadcast. This program is being recorded and will be available on the Partnership's YouTube channel. We will be muting all attendees' microphones during the presentation, but we would love to hear from you. Please write questions in the question box, and the speaker will respond to as many as possible at the conclusion of the presentation. Now I would like to introduce today's speaker, Dr. Damali Campbell. Dr. Campbell is a board certified in both obstetrics and gynecology and addiction medicine. Her special interests include advancing health education for women, promoting and supporting breastfeeding, and addressing social determinants of health to improve outcomes. Dr. Campbell currently works at University Hospital in Newark, New Jersey, and is an assistant professor in the Department of Obstetrics, Gynecology, and Reproductive Health at Rutgers, New Jersey Medical School. She's also the medical director for the New Jersey Department of Health Maternal Care Quality Collaborative. Thank you, Dr. Campbell. We're so grateful to have you with us today.
Thank you for inviting me, and thank you for everyone who is attending this hot topic, very timely topic concerning cannabis use with new parents and breastfeeding. So I do not have any disclosures, but I do want to point out I have been in practice for a couple of years. I don't want to date myself. But my answers today may be different than they may have been a few years ago. If you and I have had this conversation 10 years ago, my answers to some of these questions may be a little different than now. So here are some of the objectives that we want to review today. What's the available information regarding marijuana use in women of childbearing age who are pregnant and parenting? Review the available evidence on marijuana and breastfeeding, and work through some case examples and how we can have some of these challenging conversations that we face discussing these issues with women and their families. So I want to just start out by bringing a case up. Perhaps you've met this person. If it sounds like somebody you may know, there's no resemblance. It's just a surrogate case, but 24-year-old is referred for counseling. She recently found out that she's pregnant when she missed her menses for 2 months and took a home pregnancy test. She screened positive when the provider asked about substance use and noted that she had terrible nausea and vomiting and noticeable weight loss. And she was coming in at 16 weeks. She didn't have insurance before when she initially found out that she was pregnant. And because she had such terrible nausea and vomiting, a friend told her to try cannabis to decrease the nausea, which she did, and it actually helped. And her prior use, prior to this experience, was just recreational, maybe once or twice a year. Or perhaps this sounds familiar. A 30-year-old with chronic neck and back pain after a car accident. She was taking narcotic pain medicine on and off, but didn't really like the way it made her feel. She found that smoking weed reduced and eliminated her use for a narcotic pain medicine. If she doesn't smoke weed, she feels anxious, on edge, and her back tightens up really bad. She was recently diagnosed with the first trimester pregnancy, which was unplanned but desired, and she had 2 prior uncomplicated deliveries prior to her car accident. So here are some of the reasons that people cite the use for marijuana. Sometimes it's just recreational and fun, and people are with their peers. And at other times, they note that they need it or they use it to help stimulate an appetite, to reduce pain, to reduce anxiety and just help them to relax, to reduce nausea and vomiting, or to manage a chronic medical condition. And many of you who listened to the lecture that was given about marijuana and breastfeeding, marijuana and pregnancy that occurred in last month, we know that there are two major strains, two main types of cannabis. Cannabis indica, which has larger amounts of cannabidiol, otherwise known as CBD, and is known for relaxation and is commonly used to relieve inflammation and glaucoma. It's also used by some who have difficulty falling asleep, used by some people to mitigate weight loss and for pain relief. Cannabis sativa has larger amounts of tetrahydrocannabinol, which is abbreviated THC, and is known to be more energizing, can reduce headaches, pain, and nausea, and can also stimulate the appetite. But mostly cannabis sativa is known to be more stimulating, but it does have a higher tendency to induce anxiety or paranoia. So, most patients that I talk to, they say it's natural, right? And in their mind, I think what they are saying is because it's natural, it's harmless. But as medical professionals, we know that cannabis has physiologic effects. It temporarily increases the heart rate and blood pressure. It increases the risk of cardiac arrest and stroke. It can interact with prescription medications, especially barbiturates, CNS depressants, theophylline, warfarin, and fluoxetine. If people are scheduled to have surgery, they should avoid marijuana because many of these types of medicines are used with anesthesia. And in combination, they can cause excessive sedation and diminish motor coordination. Cannabis distorts perception. It distorts sights, sounds, time, and touch. The chronic use of marijuana increases the risk of impaired cognitive functioning, memory, and decision-making. Depression and anxiety, weakens the immune system, can cause infertility. And there's actually something known, very paradoxically, because many pregnant women say they're using cannabis to mitigate nausea and vomiting, but there's actually a syndrome called cannabinoid hyperemesis syndrome. And again, the chronic use of smoked marijuana increases the risk for oral cancer, chronic bronchitis, and frequent upper respiratory infections. So this idea that this substance is natural and therefore harmless is really unfounded. This is just a little data from SAMHSA that just looks and reminds us that among women, marijuana is the most used drug, and that has been a significant increase in that use over, particularly in the younger population. And again, why is this worrisome? I think for a number of reasons. One is because we are concerned about what's called a gateway drug. So what's a gateway drug? A gateway drug is a drug that's not always habit forming, but can be. It's a drug that can lead to people using harder drugs, or what we would consider harder drugs. And that kind of terminology, I guess, is subjective. And then the secondary, if you use more than one substance, obviously, that is not good, and it can also be more addictive. I think two other points about that we should be worried about cannabis is that, number one, because of the legalization, there has definitely been a greater acceptance, and with that acceptance, we see an increase in use. And the second thing is that cannabis can be mixed and extended with other substances that pose additional threats to the health of the mother and infant. And so I can't tell you how many times in my work I have seen women who say, I'm just using marijuana, and when they have a drug screen, we find that they're testing positive for PCP, for fentanyl, for other substances that they are not aware of that was in what they thought was just marijuana. I also just wanted to bring to your attention that there are biological differences in how substances interact in our bodies and are metabolized by women different than men. So not everyone is aware that women metabolize nicotine faster than men, and this results in more difficulty in the use of nicotine patches for quitting for women. Women are also more sensitive to social stimuli associated with smoking, and that is true whether it's tobacco or marijuana. And so it's just important. There is a particular concept that's called telescoping. No matter what substance you look at, women, they can become addicted in a shorter time frame. And so that is called telescoping. And that's an important concept that we need to be aware of that occurs in women. It's specifically related to marijuana, gender differences noted in substance use. And this again is information from NIDA. Fewer men use marijuana more than women, but marijuana affects the spatial memory more in women. Teenage girls with regular use of marijuana have higher risk of brain structural abnormalities. And women who use marijuana and have associated mental health problems tend to have more anxiety and depression, whereas in men, we tend to see more antisocial personality. And of women who do use and develop use disorders, again, they tend to develop these disorders more quickly. So back to that concept of telescoping. And the social ramifications for substance use are different for women. Prior to its legalization, child welfare involvement and the loss of child custody is a particular concern and fear for women. Legal ramifications, incarceration, divorce, and job loss are all factors that particularly influence women more than men. I just wanted to show you this timeline that was created by Third Way, which shows over time which state have made laws to make marijuana medically or recreationally legal. So we can see go all the way back to 1996, where the state of California initially made marijuana medically legal. And then look at how many places there are in 2000. This only goes up to 2016. And so this particular group, Third Way, really goes into the policy issues that although each of these states may have legalized marijuana, these state laws are not all created equal. And again, this is another map in different states where marijuana is legalized for medical use versus decriminalized versus legal for medical use, for recreational use, or just decriminalized. And this is updated as of April 2021. So why do folks continue to use marijuana? I think, honestly, there's a lot of mixed messages. We know that cannabis use has more than doubled among pregnant women in the United States, and we believe that much of that has to do with the greater acceptance, with the legalization, whether when we say legalization for medicinal use, then people think, well, if it's a medicine, then there's no effects. But we all know that there are side effects to medicines. And so this increase in legalization has definitely affected acceptance and has definitely affected use. There are stronger marketing strategies and messaging that reach the public from dispensaries and legalization organizations than from the professional medical organizations. So the highway that I drive down, I always see a billboard that has something favorable about the legalization of marijuana. But when do I see billboard messages from American Medical Association or American College of Obstetrics and Gynecology warning about the dangers of marijuana usage and during pregnancy or even during driving? So there's a mismatch. There's also a mismatch between lactation professionals and professional organizations. So all of these things are really affecting how people see marijuana as whether it's okay or not okay. And the US Surgeon General in 2019 did particularly make a statement about warning on marijuana use in adolescence and during pregnancy. So we mentioned already that we know that cannabis use has doubled from 2010 to 2017. And we know from this particular, from the JAMA online journal, it was reported that cannabis use in pregnant women has increased from 3.4% to 7% between 2002 to 2016. So over the same time period, first trimester cannabis use increased from 5.7% to 12.1%. And so this is just what is self-reported on medical and non-medical use among pregnant women in the United States. So I believe that we can safely assume that this is an underreporting. And so really, in my mind, this becomes a conversation about the risk and about the benefits. And do we have a strong enough voice to talk about what the risks are? Ultimately, what I try to explain to patients is there's no amount of marijuana that has been proven safe to use. Using marijuana during pregnancy can cause problems for the baby. And some of those problems include premature birth, problems with brain development. And plus, we have safer alternatives for medicines that can treat nausea and vomiting, anxiety, and some of the particular concerns that patients may have. And if a woman is impaired while they're using marijuana, how can they safely care for their infant? We know that for a fact, marijuana is in the breast milk. And not only is it in breast milk, but it is stored in the fat, not only of women's bodies, but in the fat of babies' bodies. And so that marijuana can be released over time. And that's why we know that marijuana lasts in the system for such a long time. And so what are the professional organizations saying about marijuana and breastfeeding? The American Academy of Pediatrics says absolutely not, and advises women to refrain from breastfeeding if they're going to use marijuana. ACOG says breastfeeding women should be informed of the potential exposure to marijuana metabolites, and that exposure is unknown and should be discouraged to use marijuana use. And the Academy of Breastfeeding Medicine, again, doesn't have as clear of a statement. And I think, they have, and I have been to, prior to COVID, recent conferences where there has been a lot of talk about whether we should be promoting, because we are so, you heard from the bio that one of my important things that I think is really important is supporting and promoting breastfeeding. And so the question is, are we willing to give up the benefits of breastfeeding? But again, it goes back to the risk and benefits. So what I can say is that in recent conferences that I've attended in the Academy of Breastfeeding Medicine, they have had a position of discouraging marijuana use. I just wanted to point out, just through this particular slide, the characteristics of marijuana use. So this was done by the federal government, and they looked at 8 different states that participated, and they looked at the characteristics of use during pregnancy. And so you can see that the use is always higher before pregnancy, and then there's a use that's during pregnancy, which goes down, and just in a couple of places, the use after pregnancy goes back up. So again, this is just 8 states, but it tells me that clearly there is some messaging that's going forward that women feel that they should stop using during the pregnancy, but then after pregnancy, it looks like there are some women who are going back to breastfeeding, going back to marijuana use. So why is it so difficult to understand and study the effects of marijuana in pregnancy and lactation? And I think it really just comes down to who's raising their hand to say, I use marijuana. I want to be in the study. We have, don't have a lot of folks willing to participate in studies, So that's one problem, the recruitment. There's such a stigma that is associated with substance use. And as I told you, that stigma translates, and as it affects women differently, fear of custody loss, their children, ramifications with child protective services. Nobody's raising their hand. I want to remind us all, and I was in another presentation a couple days ago, and someone else showed this slide, and it relates to opioid use, but again, it relates to any substance use, and the words that we use are very important. So when we talk about a drug test being clean or dirty, even when we're talking about marijuana, we need to think about how that word can be very stigmatizing, and how in a very implicit way, in a very unconscious way, how that makes us react to that person. Their urine is dirty. So there's a lot of stigma. But all things considered, the short answer when a patient asks me, is it okay if I breastfeed and I'm using marijuana? And some patients will say, well, I'm not smoking, I'm eating an edible, I'm using an edible, or I have a medical marijuana card because I have, a medical need for this. The short answer is no. But I think the short answer really doesn't get to the heart of what we really need to, where we really need to be. And I think where we really need to be is what's the bigger conversation we want to have, and how do we have that bigger conversation? And so here I just gave some suggested questions that can maybe help us to have a conversation or start a conversation. Do you know what factors affect whether drugs or chemicals or any substances are found in your breast milk? We can't just assume that people understand. Maybe people don't understand that because particularly marijuana is lipophilic. It attracts to the fat cells. That's what makes it hang around so long. It makes it linger. Whereas other substances that are not as lipophilic, they're in and out of the system very quickly. If I had money for each time I would give a pregnant patient, a prescription. It happens all the time. I see pregnant patients, initial OB visit. We do this routine labs. Maybe a few patients might come up with a urinary tract infection. So I give them a prescription and say, you have a UTI. I'm going to give you this prescription for antibiotics, and you need to go home and take it twice a day, drink lots of water. First thing the patient says back to me is it okay if I take this when I'm pregnant? So, sometimes I want to say, like, if I say to a patient, if I gave you a pill, not knowing what's in it, what it would do to you and your baby, would you take it? If I gave you this pill, I don't know what it's going to do to you. I don't know what it's going to do to your baby. Would you take it? Why? Why not? Is everything that's natural good for you? Because again, we have these words, natural. It's a plant. Digoxin is a plant, but it's a medicine. And if you get too much digoxin, it can kill you. Poison ivy is a plant. So this idea that everything that is a plant or everything that is natural is good for you has to be challenged a little bit. And are you aware that depending on the storage and packaging, that marijuana can be contaminated with bacteria like E. coli? Do you know how smoking marijuana differs from edible marijuana? So again, it just speaks to some patients know that smoking is bad and about the other chemicals with smoking, but do they know the dangers of edible marijuana, the onset of action that's much longer? So just to try to keep you engaged, what's the age? We didn't get to do the poll, but maybe people can put in the chat box, what's the legal age for recreational use for those states that have legalized marijuana for recreational use? What do you guys say? 16 and up, 18 and up, 21 and up, 25 and up? I'll give you 30 seconds to put your answers in the chat box. I can't see the chat right now, but so what do you think? What's the age for recreational marijuana use in those states that have legalized marijuana for recreational use? So hopefully most of you know that in all states where marijuana has been legalized for recreational use, it's still only legalized for those 21 years and above. So these are the facts. Marijuana used in all its forms is found in the breast milk. Marijuana compound is lipophilic, meaning that it stays in the fat cells. And this is one of the reasons that it can stay in our system for such a long time. The potency of marijuana has increased over time. And I believe that that is contributing to why we're seeing more addictiveness and more effects because of the potency of today's marijuana. And marijuana has a negative effect on the developing brain. We know for a fact from studies done in teenagers that and we know that the brain is not fully developed until 25. So we know that our adolescents that use marijuana, that marijuana has a greater effect on their brain development. So that's what brings a question to bear, you know, is this the same effect in babies, in infants, in toddlers? But again, we don't have all of those studies and we don't have these numbers to prove that. And that's what we're working on now. This slide was just really to demonstrate the percentage of THC and CBD, those components that we talked about in cannabis over time, and the fluctuations that you can see. And so again, it goes back to the bigger discussion, which I like to try to use open-ended questions, get the patient talking to me, and so that I can see where they're coming from rather than me just trying to lecture at them what they should or should not do. Do you have any concerns about how your use will affect you or affect your baby? Have any of your family members complained about your marijuana use? How accepted is marijuana use in your family? What do you think would happen if you stopped using marijuana completely? Are you concerned about secondhand marijuana smoke and your baby? Most people who, many people who I see, and I'm sure many women that you see, the facts are the vast majority of women, when they find out they're pregnant, will stop smoking marijuana, will stop using alcohol, and will try to limit or stop using cigarettes. So it's really important for us to know about those women who cannot stop, because that again points to a level of addiction, right? Because most people will know, they will say, yes, I know this is not good, so I'm going to try to cut back, I'm going to try to limit. So it's those people who can't that need our help. And unfortunately, unlike opioids, we don't have a medicine that we can give them that replaces, that interacts with those cannabidiol receptors on our bodies. So I wanted to just kind of go through a couple of cases. We talked about case one. I mentioned case one, so I just wanted to go back to it. You know, think about, you know, what we would do. And again, this is a situation where the woman found out she was pregnant. She had used recreational marijuana before with friends, you know, a couple times a year, but really she just tried cannabis in this case when she found out she was pregnant because of terrible nausea and vomiting. And so, you know, and this is a very common situation because some patients don't have insurance when they find out they're pregnant. And there's a whole process of application. And so this is a common situation that I see. And, you know, again, like I said, I try to let people know there are safer medicines that we have far more knowledge about their short-term and long-term safety during pregnancy. So we always want to try to steer them to medications that we know are safer in pregnancy. But it seems like this young person is probably not addicted. She just was trying to mitigate her nausea and vomiting. And like most patients, will be able to stop pretty easily with appropriate counseling. In case 2, a little bit more challenging because this is a patient with chronic pain. And so she's already tried the situation where she already tried not smoking and is saying, when I don't smoke, I feel anxious, I feel on edge, and my back tightens up terribly. So she's already giving you not only some physical symptoms, but also some anxiety symptoms from her discontinuation use. And so, again, this is going to be a patient, that we're going to have to, again, try to convince her that we don't know anything about the effects of marijuana in pregnancy, but we do have some other medications that we can use that might help with her chronic pain. And C, then now what are we going to do about her anxiety? We're going to have to deal with that as well. Is this a situation of PTSD? Is there a baseline anxiety disorder? So we're going to have to deal with that. So it looks to me that it's going to be a little bit more challenging. In case 3, this is a new case. A 25-year-old presents for prenatal care in the first trimester. The provider screens for substance use, which the patient reports marijuana is due to an anxiety disorder. And she's under the care of a therapist and has a valid medical marijuana card. And prior to use of marijuana, she tried other anti-anxiety medications, which had not been successful. And the patient really just inquires, is this going to be a problem when she goes to the hospital in regards to taking care of her baby? And I think this case really just speaks to the fact that, this is a fear. If patients think that our ultimate, that we're going to threaten by taking away their kids, or, some type of action or supervision, they're not going to tell us about their substance use. So, with this patient, it's important to acknowledge that she has a valid medical marijuana card. But again, we have to just explain to her that we don't, even though she has a valid medical reason for medical use by a provider, we still, at the end of the day, don't know all of the long-term effects on marijuana in her pregnancy and in her breastfeeding. That's why we avoid it. That's why we counsel against to avoid it. And so, the patient is already telling us that she's tried other anti-anxiety medications that were not successful. We can gauge the patient's acceptance of possibly trying something else. Sometimes, you ask the patient, what did you try? Maybe it was a long time ago. Maybe there are newer medications available. Maybe they only tried it for a short period of time. So, there could be some wiggle room if the patient is willing. If she's not willing, then the best you can do is counsel her. And I do believe in harm reduction. And what that means is that sometimes we have to accept that what we are doing is counseling and advising, and everybody may not take that counseling and advice. But I feel, and I honestly believe, that if we give that counseling and advice and the patient doesn't initially take it, there's an opportunity where we can leave the door open, or we can close the door. We close the door by just saying, okay, you didn't listen to me. I told you this is not good for you, and that's it. Or we can leave the door open. I respect your decision. I'm here to help you. I can imagine how difficult this is. But again, ultimately, I know you want what's best, and I'm trying to help you with what's best. And to me, that leaves the door open for the patient coming back, and maybe taking advice to lessen the use to the least amount possible, if they cannot stop altogether. And we do the same thing with cigarettes, right? I mean, we want patients to stop altogether, but it's not that easy just to stop. So sometimes we have to be willing to also accept if the patient cuts down, and we will still counsel them to try to stop. I'm famous for telling patients, you're down to 1 to 2 cigarettes a day. That's fantastic. Then you could probably just stop. You're only down to 1 cigarette per day, but maybe that last 1 cigarette is the hardest one for them to give up. And then case 4 is a patient who's 35 years old with a history of rheumatoid arthritis. She has chronic pain on Percocet 1 to 3 times per day, recently discovered that she has Miss Menzies, has tried to cut down on taking Percocet once a day, but notices irritability and sweats, and in addition also uses marijuana to assist with the pain. So again, we have a situation where sometimes people with chronic medical conditions are using marijuana to reduce their use of chronic pain medicine. So this is a patient that maybe I can do the most for, because she is on an opioid pain medicine, so I can, assist with offering prescription for buprenorphine, which could help with some of her pain, so that if we can get her pain under control, that she would not need to rely on taking Percocet, and again, the irritability, and also the marijuana. But she's showing the physical signs of opioid dependence based on the irritability and sweats when she tries to cut down. So I also just included this particular pictograph, which you can go to the website. It's from a New England website, and you can actually personalize this particular graphic with your organization's logo. And I think it gives some key points here that I thought were very helpful. And I hope that you all will find it helpful as well. And so here also are more references, but I know we have a few minutes left, and I'm eager to hear what's going on in the chat and to just have some dialogue.
Great. Thank you so much, Dr. Campbell. I think this is really helpful for so many of us who want to know the right thing to say and how to address it. We have a few questions that came in. The question box is still open, so feel free to continue to ask some questions. The first question was, the AAP identifies second and third hand tobacco smoke as a risk factor for SIDS. Have you seen any evidence or research on marijuana second or third hand smoke also being a risk factor for SIDS?
That's a great, fantastic question. I actually looked for this myself because I wanted to actually do a comparison. And the sad part is there's just not a lot out there. There's not a lot out there. But one of the reasons why I compare to second and third hand smoke is because I also feel that, just from my knowledge of questioning patients, that very few patients just only smoke marijuana. So most have a combination. And so it's still applicable. The issues of second and third hand smoke is still applicable to them.
Okay, great, thank you. Another question, you may have addressed this, or you could speak to it from your experience, but why would individuals believe it is safe while breastfeeding? Is this a controversy that's going on right now?
So I think that, again, when you think about the history of marijuana use over time, even prior to my own birth, marijuana had a very low potency. It was seen as something to kind of relax and to let your hair down. It wasn't very harmful. And so you actually did have some lactation specialists who were saying, like, what's the big deal? If somebody, has a little puff every now and then, it's not a big deal.
Yeah.
That was then, this is now, right? Again, the potency issue is a huge one. And now I can't emphasize enough, and I emphasize this to patients all the time. You think that you're getting one thing. The police, the DEA, they actually do drug testing on confiscated drugs. And so there's so much fentanyl out there in some of these substances, which, number one, makes it more addictive, makes people want to come back to it, right? But the person thought they were getting marijuana, but now they're getting marijuana and fentanyl. They're getting marijuana and PCP. So do you really know what you're getting?
Right. Another question is, thank you very much for this informative presentation. As a doula, I get asked often about the use of CBD during pregnancy and breastfeeding, the oils and creams. I'm interested to hear your thoughts on the use and the topic, difference between the effects of THC versus CBD, and the recommendations for CBD use during pregnancy and breastfeeding.
Yeah, great question. I can imagine that there are lots and lots of people who are asking about, because there's so many different, how can I say, preparations or formulations of these substances. And so at the end of the day, what I have to end up telling people is, I don't know. And that sucks, right? Because nobody wants to hear, I don't know. They want me to say it's good, it's bad, I guess the guidance that I try to give people, if it's any other substance, if I was to tell somebody, here's a medicine for high blood pressure, I don't know if it's going to be good. I don't know if it's going to be safe for you to take if you're pregnant, or safe for you to take if you're breastfeeding. Would you take it? So I think what I have to do is just kind of bite the bullet and say, I can't, in good conscience, tell you to take it when I don't know what the effect is. Until we have more information, I can't say it's okay. That doesn't mean it doesn't mean that I'm going to leave you out there, or I'm going to disapprove of you, or I'm not going to take care of you. It just means that I can't reassure you it's okay.
Right. One question is in regards to nicotine gum and patches for men versus women, that they're less effective on women. What do you recommend for women to use to quit smoking?
So, I mean, yeah, like I, mentioned, the biology is such that the patches, the nicotine replacement doesn't work as well for women as it does for men. It doesn't mean I don't use it for women. There are other treatments for women that we do use, but I do still use nicotine patches and gum, and sometimes I use them in combination. So what I find is that sometimes women will take the patches and they still have a lot more cravings. And again, women are much more susceptible to the craving cycle in addiction. So at that point, what I tell them to do is take the gum. They can chew the gum to get rid of that immediate craving. So a lot of times what I do is in combination. There is Chantix for women. They can use. The acceptance is not that great, but it is an option if the patient is willing.
Okay. Another question is about, why doesn't ACOG recommend drug screening as routine lab work for their patients? Do you think this would possibly decrease drug use?
Yeah, I don't think that requiring everybody to do a drug screen is going to decrease drug use. If you already look at the internet, there's about a million solutions on how to get your drug test clean. So I think that if we say, we're going to drug test everybody, when they come to be pregnant, people are just going to stop coming to be, coming to identify that they're pregnant until they can screen negative. And the argument for not doing drug testing universally is that drug testing only tells you about a moment in time. Only tells you about a moment in time. It doesn't really get to that larger issue that screening can get to by actually talking to the patient and finding out, they've discovered they're pregnant. How often have you used marijuana in the last month? That's going to give you a better picture than just doing one test one day in time. Hope that makes sense.
Yeah, it does. It does. And speaking about harm reduction, one question is switching from smoking to eating edibles considered harm reduction?
I think people do think of it as harm reduction because with smoking, you have twofold issue. You have the exposure to marijuana itself, but then you have all the other compounds and chemicals that are associated with smoking. So I do think that it is seen as a harm reduction strategy. On the other hand, the problem with edibles is that there's a longer onset of action. So, and typically what happens with edibles is that people may not get that immediate effect that they may have been used to with smoking. And so then they eat more because they're waiting to get that effect when it takes longer. And so do we really know, is a person going to now be using more because they're trying to get to this peak effect? So yes, on one hand, you see that they're not smoking. They don't have the 700 other compounds that are in smoke, but then maybe they're using a higher amount of marijuana.
Okay. There's no clear-cut answer to all of the questions.
No. You guys want to throw tomatoes at me. She's not answering.
Another question about, there is so much debate on CBD products. Is there THC in CBD products, and what guidance can be given to pregnant women and others about CBD products as far as testing positive for marijuana?
Yeah, I mean, that's part of the problem, right? These companies are not regulated by the FDA. So they say, oh, it's only CBD, or it's only this, or it's only that, and it's natural. And what does natural really mean? So that's part of the problem. Patients don't necessarily know what they're getting. It's their trust. They believe what the label says. The label can be incorrect. It's been proven, they have looked at some of these products, and some of these products that say they're only CBD, they have examined them and found, certain percentage of them have, in addition to CBD, they also have THC. So that's what the problem is.
Yeah. Yeah. Another question is, I work in a mother-baby unit. At what point should we be calling DCP&P for cannabis use?
Yeah, that's a toughie, right? So, so every institution is going to have their policy. And I think that it brings up a really important point. Despite the fact that different states have legalized marijuana federally is still illegal. And so, the Division of Child Protective Services and some of these guidelines are coming from a federal level. And so we have to follow our institutional policies, in regards to how we call. I think the division is probably looking at how this is going to be, how it's going to affect them and the calls that they're going to get. In my institution, what I'm told is that just a patient using marijuana is not enough for DCP&P to take away someone's baby, because we ask these questions, because the patients are asking the nurses and the clinicians these questions, right? But if they find that there's marijuana use and additional risk factors or red flags, then that might open up a case. But just marijuana use alone, I'm told, doesn't automatically open up a DCPNP case. But I'm sure that you guys on this webinar can speak to a more diverse experience where that comes from.
Okay. And one last question about breastfeeding. As a baby gets older and eats food in addition to breastfeeding, does occasional use of cannabis become less risky?
So, I mean, in my mind, I'm thinking if the baby is breastfeeding less because they are eating food, then their exposure is less. The problem is, I think, and that we don't know the answer to, that we're trying to find the answer to. So we know that cannabis is in breast milk, and how long it stays in breast milk is really the question that we need the answer to. How long, right? So we know that we can see that cannabis stays into the system, up to 30 days. If we're doing urine screening, is that the same for milk? There's Dr. Hale. If people are familiar with Dr. Hale's work, he's doing a lot of studies about this, now. And even, the last Academy of Breastfeeding Medicine conference that I went to, he talked about some of the struggles in recruiting patients, because even in Colorado, where it's legal, again, who wants to raise their hand and say, yeah, because people are afraid of, what's going to happen with custody and stuff like that. So these are some of the answers that we need. My instinct tells me it's probably not as dangerous, but we can't say there's no danger, there's no risk at all, because we know that cannabis is in the fat cells. It's released slowly, not only in the mother, but remember, in the baby too. So the baby is breastfed milk that has cannabis in it, it gets stored in their fat cells.
Yeah. All right, Dr. Campbell, thank you so much for coming and speaking with us today. And we hope we can have you back at some point when we have more research to share and evidence to support. But we appreciate having you today. Karim Amadeo, also, thank you, who is handling the technical backend. And thank you for everyone here who's joined us today. As a reminder, you'll receive an invitation to take a survey after the webinar ends, as well as we'll receive an email with a link to a post-program evaluation. Your feedback is important, so please take the time to complete. And the certificates of completion will be sent via email you provide on the evaluation and should be received in about a week. A calendar of the partnership's upcoming virtual programs can be found at www.pmch.org under the Professional Education tab. We welcome you to join us at the partnership's annual meeting next week, when Dr. Joshua Sparrow, the Executive Director of the Brazelton Touchpoint Center, will be presenting on understanding trauma and ways of healing. We also offer on-demand recordings